for the invitation.
No problem.
Oh, okay, got it.
Yeah, well,
Okay. There we are. Okay. Well, thanks for the invitation. Great pleasure being with you, of course. And hello to everybody out there. I'm sorry not to be with you for real, but there we are. That's life. So there's quite a lot of data in what follows, but I have tried to make it a bit more interesting by bringing in filling in the historical background, fascinating historical background to the rise of mass medicalization of the past 2 decades, and the personalities involved. So my talk essentially has 3 broad themes. The first is how it is that over the past 20 years, the number of prescriptions issued by family doctors has increased 3-fold, a phenomenon first highlighted back in 2006 by Dr. David Gerard in the Porter Medical Journal, and which he dubbed escalating polypharmacy. Next, I'll be drawing attention to the serious adverse iatrogenic consequences for many, especially the elderly, and finally to consider what might be done to reverse it. There are a couple of caveats. My analysis and the evidence presented is obviously pre-COVID. But despite the profound impact the pandemic has had on medical practice, the situation and trends I describe persist as before. And next, I hope you interpret my comments in the way intended, not as an overly pessimistic critique of current general practice, but rather an attempt to get to grips with and comprehend a most serious problem that needs addressing. So I don't think Becca mentioned, but I have for the last 30 years written a weekly medical column for The Telegraph. And my first intimation of the problems posed by escalating polypharmacy came in a letter from a man in his mid-70s who 3 years earlier had undergone a successful repair of his aortic aneurysm. So rather astutely, he'd actually diagnosed himself. Anyhow, subsequently, he had not done well, and had gradually gone downhill, immiserated by muscular aches and pains in his legs that eluded both diagnosis and treatment. He was, however, determined to go and visit, to attend his son's wedding in distant Hawaii. A difficult journey, as you can imagine, involving a wheelchair at several stopovers. And when he arrived, he discovered that he'd forgotten to pack the drugs he had been prescribed for aortic aneurysm repair. But the consequence of not taking them was that 2 weeks later, he walked back through Heathrow Terminal Heathrow unaided. And a remarkable story, I think. But more astonishing still was the response, which was 2,000 or more letters from readers of my column and elsewhere, which obviously inform my views of the issue of polypharmacy and its consequences. And they're eloquent. And I'll just give you 3 or 4 to give a sense of the flavor of the sort of problems that people encounter. And the first is from a woman who was, she say, frightened into taking statins by my GP. When I asked him what the side effects might be, he answered, "You will live longer." The actual side effects were lack of energy, insomnia, weight gain, etc., etc. I eventually chucked them away, and 2 weeks later have regained my energy, sleep like the proverbial log, lost 5 pounds, and any muscle aches are now caused by my tearing around like a teenager. And the next is from a woman whose husband was taking 10 different medicines. And this is what she says. My husband has lost all confidence. He gets up in the morning with no energy. And this continues all day long. He's not able to work in the house or garden. He occasionally washes the dishes, but this is too much for him. His life stretches out with no hope of improvement. On inquiring about the necessity for taking so many medications, the GP said he would not be here if he stopped any of them. And the third is from a woman in her 80s who on antihypertensives, and she tells this story. I have had 2 nasty falls. I just went down and hit my forehead. Nothing broken, luckily. 2 black eyes and a huge lump. I felt so unwell, my doctor took me off the tablets, saying there was little difference in my blood pressure, whether I was on them or not. I feel much better now. And finally, this heartfelt plea from a woman in Norwich. What advice do you have as to how we can prevent over-medication by our doctors without antagonizing him or her? Quite a number of people I know are fearful of seeing their family doctor because of this. Your guidance would be much appreciated. Well, they are. That is an extraordinary collection of letters, not only because of the, I think, because of the stories which they tell, but also in a sense, I mean, they're not overly critical of their GPs, but the sense that they, the GPs were in a sense dismissive of their problems and their complaints. They were unappreciative of the nature of the side effects that they were causing and the misery that they were causing. And that, I think, is a very important insight. Anyhow, that's them. Now, they are, one might say, eloquent testimony to the consequences of that upward spiral in prescribing. 2 aspects of which I think warrant special emphasis. The first is shown in the next slide, where you can see that upward spiral is primarily accounted for by 3 classes of drugs. Statins, anti-diabetic medicines, and antihypertensives. Between 1994 and 2012, we see, for example, that the number of diabetes medicines increases fourfold, from 10 million to over 40, antihypertensives, 7-fold. And the cholesterol-lowering statins more than 20-fold. And the next important thing is to emphasize is that this problem of escalating polypharmacy is overwhelmingly an issue for those in their 70s and beyond, as I'm sure we are aware, but vividly revealed by the findings of this longitudinal study that itemized the number of drugs taken by age. First in 1994, that's CFSA1, and second again in 2008. And if we just stick to men, 75 plus, we see that in 1994, 19 of them were not taking any drugs. By 2008, that had fallen to 6.7%, whereas the numbers taking more than 5 had increased from 12.3 to over 65. That's pretty amazing. Now, there might, of course, be a good reason for their taking all these medicines, but as the Scottish philosopher David Hume observed in rather different circumstances, it is impossible to separate the chance of good from the risk of ill. There is no drug that does not cause side effects in some people, and the more taken, the greater the risk. They increase from 13% of those taking 2 drugs, 58% for those taking 5, and 82% for those taking 7 or more. And these are not trivial adverse drug reactions, because as we can see from these figures, the total number of hospital admissions due to ADRs, that is to say where the adverse drug reaction was sufficiently severe to warrant emergency hospital admission, increased from 1999 to 2015, almost doubled from 42,000 to 92,000. Then polypharmacy is also a major contributory factor to what are known as the geriatric syndromes, functional decline, cognitive impairment, and falls. And they're almost certainly a contributing factor to the recent rise in mortality. Here we see in this graph of the way in which since 2010, there's sharp uprise in mortality, again, especially in the older age group, commented on by Nigel Hawkes in the BMJ, the curious case of 600 extra deaths a week. The figures are fairly sensational, he says. Averaged over the first 26 weeks of 2013, there have been 10,500 deaths a week, which is roughly 600 more than would have been expected. That is enormous. Now, medicine is a sophisticated, as we all know, is a sophisticated and very successful endeavor. So when things go seriously awry, as would seem to be the case here, it would inevitably be due to a synergy of factors. Three groups in particular have been instrumental in the promotion of mass medicalization, if for quite different reasons. And they are Big Pharma, our friends, the epidemiologists, and I'm sorry to say, general practice. We start with Big Pharma. And one man in particular, who you will not have heard of, Henry Gadsden, chairman of, at the time, the world's largest and most successful drug company, Merck. Back in 1976, in an interview with Forbes magazine, Gadsden expressed his disappointment at the restricted market for his company's products, which were targeted, obviously, enough at curing the sick. Ideally, he said, he would like to sell to everyone, just as Wrigley's marketed their chewing gum. Why so? Well, by the mid-70s, as we can see from this graph of the number of new drugs, the rate of therapeutic innovation was in marked decline. Gadsden's brilliant insight was to realize the future of the pharmaceutical industry must lie in growing the market, targeting the millions of the healthy, portraying their physiological parameters of cholesterol and blood pressure as being too high and warranting long-term indefinite treatment to lower them. His strategy, put simply, was to extend the undoubted benefits of treating the relatively few with, for example, markedly raised hypercholesterol levels to the millions more by lowering the threshold for initiating treatment. As shown in the following slide, where lowering the threshold for initiating treatment of cholesterol from 6 to 5 increases the proportions eligible from just over 12% to 30% of the population. And that's a lot of people. Now, it was likely to be difficult to convince doctors that this was a desirable move. But almost until 10 years later, when this man, who you also may or may not have heard of, Geoffrey Rose, professor of epidemiology at the London School of Hygiene and Tropical Medicine, provided the intellectual rationale for doing so. The crucial point, Rose argued, in this very influential paper, Sick Individuals and Sick Populations, was that it was not just individuals who were sick, but the whole population. Everybody's blood pressure and cholesterol was too high. And so shifting the bell curve of their distribution leftwards would not only reduce the number of strokes and heart attacks, but in those with markedly raised risk factors down here, but also in everyone else as well. The effect of the combination of Gadsden's strategy of lowering the threshold and Rose's population approach, as it is called, can be seen in the following table, drawn from American data, but reflecting the situation here in Britain, that quantifies the consequences of lowering the threshold for initiating treatment. And here we have, for example, hypertension, lowering the threshold from 160 to 140 for systolic, diastolic from 100 to 90, increases the number of new cases by 13 million, which is an increase of 35%. Again, lowering the cholesterol is measured in a slightly different way there, from 240 to 200, increases the number of new eligible cases by 42 million. And similar situation for diabetes. Still, polypharmacy would never have happened without doctors prescribing these drugs in the first place, which brings us to the third, if unlikely, party in promoting mass medicalization, general practice. And how did that come about? Some may be familiar with this story, but I'll retell it. Back in the millennium year 2000, Prime Minister Tony Blair promised off the cuff during a television interview with David Frost to increase spending on their health service by £12 billion. There were no immediate plans at the time as to how this windfall would be spent, but the BMA saw in it an opportunity to increase the earnings of their GP members. But if GPs were to be paid more, they would have to do more. But their priority at the time was to do less, to shed their out-of-hours commitments that have become increasingly onerous. The compromise was a new contract finalized in 2004, releasing them from those on-call commitments. In return, a substantial proportion of their future income would be determined by their success in hitting those 76 QOF targets as to the number of patients treated for a range of conditions. Prevention of heart disease, blood pressure, diabetes, and so on. Some were unhappy about the implications, like this GP from the City Eyes, Dr. Douglas Newell Jeffries. I am increasingly dismayed by the role that has been thrust upon us. It involves ruthlessly pursuing people who feel perfectly well, where the finding of any one of a multitude of minor physiological or biochemical variations can lead to a lifetime of medication, repeated blood tests and other investigations, and the adoption of a signal that diminishes their overall quality of life. I prefer the idea of seeing patients who are actually ill, rather than those who epidemiologists and pharmaceutical companies believe to be in need of drug treatment. Pretty devastating. But his protestations were to no avail, and 75% of those BMA members, of course, voted in favor of the contract. Which, in essence, entrenches Rose's population approach in routine medical prescribing, initiating that steady upward spiral in prescribing. And this would inevitably lead to the mass medicalization in the elderly, because importantly, if rarely commented on, all those physiological variables rise naturally with age. So most of those in their 70s and beyond qualify automatically for treatment. Systolic blood pressure, certainly cholesterol, and the blood glucose. Still, we live in the enlightened age of evidence-based medicine, so there must presumably be persuasive evidence that this is all to the good. And here it is necessary to shift attention just as to how doctors have been persuaded that the benefits of these drugs are vastly more useful and effective than they really are. I take here the obvious example of the cholesterol-lowering statins, whose routine prescribing to millions is legitimated by the evidence from clinical trials, the conflict of benefit, the statistical sorcery, the Q risk 2 factor score, and the routine prescription of the cardiac cocktail of statins, beta blockers, ACE inhibitors, antiplatelets, following angioplasty and myocardial infarction. So we start with the clinical trials, who's involving tens of thousands of people, whose findings were published in a meta-analysis in the Lancet, were so favorable that the lead author, Sir Rory Collins, there he is, urged that they should be prescribed to everyone over the age of 50. Statins for all over 50s to reduce heart deaths. Treatment guidelines should be reviewed in light of the findings, the experts say. That could mean that 20 million people will be taking statins at a cost of 240 million. Now, it would be impossible to scrutinize the findings in any detail to ascertain whether Sir Rory Collins' inference is correct about the need to further extend the number of those taking statins. But we can get the gist from two earlier studies. The earlier studies of the benefits of statins, and they are the WASCOPS study in, here we are, WASCOPS study in 6,500 Glaswegians, investigating the role of statins in primary prevention, and the 4S study in 4,444 Swedes, investigating their role in secondary prevention. And as we can see, the results really are very impressive. With a 27% reduction in the risk of cardiac deaths in the WASCOP study, almost a quarter, and 41% in the 4S study. But these, of course, we know, as we see here, are relative rate reductions. Expressed in absolute terms, the WASCOP studies reduced the risk by 0.4% and the 4S by 3.5%. Some of you, no doubt, will be familiar with the statistical state of hand involved. Here we look at the WASCOP study, 3,293 patients. On the placebo, 52 deaths, with a rate of 1.6. And those taking statins, 38 deaths, a rate of 1.2. 1.2 for 1.6 is 0.5%. But it is also a 25% reduction expressed in relative terms. Ditto, the 4S trial. Put another way, presenting the results of these clinical trials, as is routinely the case, in relative than absolute terms, exaggerates the true benefit almost 50-fold in primary prevention and 10-fold in secondary prevention. A more realistic picture of the benefits of statins emerges from the numbers needed to treat, as presented in this pie chart, where you find that for primary prevention, those with no known heart disease, 98% receive no benefit. Secondary prevention, slightly better, only 96% receive no benefit. So next we turn to the mathematical algorithm, the Q risk score, with which we are all familiar, and whose introduction generated a surge in the initiation of statins between 2000 and 2006, as we can see from this graph. We may be familiar with the Q-risk score, but it is only reasonable to question just how well it does predict the likelihood of a coronary when confronted with the baffling obscurity of the statistical methods by which it was derived from the risk factor data of 2 million patients. And here is Professor Julia Hipsey-Cox giving us some idea. The observed risk at 10 years was obtained by using the 10-year Kaplan-Meier estimate. We calculated the Breyer score using the censoring adjusted version adapted for survival data, D statistic and an R statistic. This is a measure of explained variation where higher values indicate more explained variation. We also calculated the area under the receiver operator curve where higher values indicate better discrimination. Now, these statistical methods, on which so many people are prescribed statins, may or may not accurately predict the likelihood of a future coronary, because it emerged that 80% of that data from those 2 million people was incomplete, warranting apparently a further set of statistical adjustments known as multiple imputations. Our final model was fitted based on multiply imputed data sets, using Rubin's rules to combine effect estimates and estimate standard errors. I can't begin to emphasize how this seems to me utterly wrong, that GPs and others routinely prescribe these drugs on the basis of a mathematical statistical computation of which they can have absolutely no understanding of its true value. Anyhow, time constraints mean I must pass over the third of those those drivers of statin prescribing, part of the cardiac cocktail, as it is known, routinely prescribed following a coronary or angioplasty, whose benefits were critically examined by the late Professor Desmond Julian, founder of the Coronary Care Unit, in this very important paper. It is worth noting, however, the potentially adverse consequences of the cocktail as described by this building surveyor. 2 years ago, I had a stent inserted following a heart attack. Prior to this, I have been fully active in my retirement, visiting sites, fighting physicians. But since then, I've been completely unable to work, spending much time resting and unable to concentrate on writing for more than half an hour. I suspect this disappointing outcome is attributable to one or more of the 7 drugs I take. If I were taking just 1 or 2 drugs, there would clearly be no difficulty in testing for damaging side effects. But identifying any harmful drugs in a group of 7 or so is a problem. Has anyone developed a practical method of doing this? To which the answer is no. So, here we are. The Glaxo pill protects my heart from the side effects of the Pfizer pill. It prevents potential liver failure due to the Merck pill. That minimizes the risk of stroke posed by the Novartis pill. That reduces blood clots caused by the Glaxo pill. The devil of it is, I can't remember the illness that started all this. So, what to do about it? I will summarize it under the following 4 headings, although because of time constraints, I'm going to have to miss out the penultimate one. We start with deprescribing. The obvious corollary of the harms of polypharmacy is that for many, reducing the number of drugs they are taking is likely to promote their health and general well-being, as indeed is the case. Demonstrated unequivocally more than 10 years ago by an Australian physician, Dr. Doron Garfinkel, in a study in which he discontinued 320 drugs in 100 elderly patients. Over the following year, when compared to a control group, the numbers in the intervention group dying, the numbers dying in the intervention group halved from 43% to 21%. And those requiring emergency hospital admission fell by 2/3. From this, he concluded, polypharmacy is a disease, and thus the specific treatment is simple, stopping as many medications as possible. Deprescribing is the cure, which one would think would be fair comment. The trouble is that there are, as we know, many obstacles to deprescribing. It's hard to stop. And here are several of them: inertia, prescriber behaviors, that's the reluctance to stop pills started by others, knowledge or skills deficits, you just didn't know enough, patients' belief about their medication, pressure to follow guidelines, and also fear of the consequences, of course. You know, if you stop a patient's pills and they die 2 months later, their relatives might draw the wrong conclusion. So where to start? A useful beginning would be to take a much more critical approach to clinical guidelines, to the plethora of clinical guidelines, recognizing, as discussed in this paper, that the purpose of medicine is not to treat diseases. Guidelines are not for diseases, but rather to promote the health of individual patients. The authors illustrate this point by reference to a hypothetical patient, a woman in her 60s, with a past medical history of myocardial infarction, asymptomatic type 2 diabetes, osteoarthritis, COPD, and depression. Oh, I've lost it. I lost the slide. What's happened to it? Anyhow, I'm sorry. Anyhow, applying those guidelines, they point out she should be prescribed 10 different drugs. And I'm sorry that I seem to have lost the slide on which they're listed. 4 of which are the cardiac cocktail already alluded to. Statins, lisinopril, clopidogrel, and a beta blocker. But as Professor Julian points out in the paper already mentioned, the evidence of their long-term benefit is highly equivocal. Thus, there is a great opportunity for drastically reducing this hypothetical woman's drug burden by not prescribing them. The possibilities of deprescribing are a lot easier when the initiative comes from the patients themselves, who not infrequently inquire whether they should be taking so many pills. And here, a series of papers and reviews published in the BMJ from 2014 onwards are immensely useful in drawing attention to the minuscule benefit for many with mild hypertension and at low risk of ischemic heart disease. Here we have John Abramson on the low risk of cardiovascular disease. Statin therapy in those at low risk does not reduce overall mortality or serious illness, with an increased risk of causing side effects that range from minor and reversible to serious and irreversible. And here is Professor Stephen Martin on the benefits of treating mild hypertension. The review found that compared with a placebo, treatment with an antihypertensive drug did not reduce any outcome, including total mortality, total cardiovascular events, coronary heart disease, or stroke. So here we see in these two papers the definitive verdict on the Gadsden-Rose strategy of lowering the threshold for initiating treatment that fueled the rise of polypharmacy. For the vast majority in whom these parameters are normal or only marginally raised, they confer no benefit. And so one can advise accordingly those patients seeking to reduce the number of drugs they are taking. I must leave it there. This is so massive a subject, I have by necessity had to confine most of my comments to talking about cardiovascular prevention. But the same considerations apply to overprescribing of anti-diabetic drugs, PPIs, bisphosphonates, and others, as described in some detail in my recent book, Too Many Pills. Finally, oh, there they are. There are those pills. Citalopram, omeprazole, metformin, aspirin, lisinopril, simvastatin, and bisoprol. These are obviously the cardiac cocktail. And finally, an encouraging last word from a general practitioner. Since I've started to look at that more globally, the number of medicines I'm prescribing on average for patients in rest homes is about 50% of what I was prescribing a year ago. And they aren't falling off their perch in greater numbers. Patients like it. They say, oh, a whole big meal of pills. And you know, people are generally better. People wake up, they're less nauseated, they have fewer falls, all those sort of things. Yeah. Thank you.
Fabulous. That was very interesting, and I think an interesting approach and quite refreshing approach, particularly as obviously in GP we've got increasing age and frailty, and I think it's something that we're going to come across more and more, trying to balance the dearth of guidelines and what patients should be on, and trying to, you know, look at what's actually right for the patient. I don't know what other people's thoughts are and if they had any questions at all for Dr. Le Fanu.
Not specifically a question about that, but I'm just, with the world that we're seeing now, especially going forward with our clinical care, obviously there's a lot more litigation. And we've seen a lot more of the fact that there's these guidelines out there, CKS and others, that suggest we should be on these drugs, and that's obviously a big balance scale we need to provide. Obviously there's a lot more. I'm just recently qualified, and there's a lot more on shared decision making with the patient, giving them the risks, and recording that we've made a shared decision together not to start these medications, going against guidelines and things like that. But at the same time, you know, we've seen a recent case with documentation, folic acid and things like that. There's all this risk that that litigation is going to come into it, and that's, I think, quite fearful for us as GPs to get these kind of messages across in 10 minutes and not have it come back to us that we're going to be sued for not starting someone on or controlling the blood pressure to the right degree, because if they have a stroke, what's going to be looked at? It's going to be looked at the numbers. No one's going to say, well, I had a discussion with the patient, you know, and there was the shared decision was there. So unless that's clearly documented, that's what I find. I'm very much trying not to be, but I think as more and more time go on, I am starting to see numbers being. I'm treating more numbers than I am wanting to make shared decisions with patients, because it's a battle with the time that we have, and I suppose a bit of fear there. So I mean, it's more of a comment than the question, but yeah, litigation is a big thing for me.
Yeah, Becca, can I somehow or other get rid of my presentation and sort of you can see? I just want
just
to
so we can see. Do you want?
What should I press escape or something?
So yeah, so just press end share screening, end screen sharing.
Okay, stop share.
Yeah, there we go. And it's you. Hello.
Yes, Richard. Well, I mean, I think that there are, you have just, very eloquently described the many obstacles to deprescribing, or the several obstacles to deprescribing. I mean, I think the first point is that the issue of informed consent, which is that prior to initiating patients on these medications for life, they have to be aware of what the risks and benefits are. And the question is whether or not, I mean, if you're going to take pills for 15 or 20 years, you need to know. And how well one presents those. Mm-hmm. I mean, do you cite the evidence of if you've got mild hypertension that I've just mentioned from the BMJ review, that treating mild hypertension confers no benefit? And despite what the guidelines might say. And this is a really, I mean, I think, this is an important issue. I mean, the point is that, does one trust to one's own independent judgment and one's own personal evaluation and knowledge and acquaintance with literature? Or is one guided by those guidelines whose basis one has no understanding, on which the evidence on which they're based, one has no personal knowledge. I think there is a sort of a way in which I view this, which is to, as it were, take the not the contrary view, but the supposition that the benefits conferred by these drugs are, as I pointed out, vastly smaller than is claimed for them. And that rather than thinking, should they be on them, thinking, why should they not be on them? I think that's one point. And I think the other thing is that one just can't get away from this. The second point. And that sort of emerged, I think, from those initial letters that I cited. And of course, I don't want to be, I'm sure that this doesn't apply to the people attending this meeting today. But the fact is that many people feel that they have been coerced into taking drugs that they don't want. And that when they raise doubts about it, are bullied, would be the right word, by comments like, well, if you don't take them, you wouldn't be here, or, they'll make you live longer, or whatever it might be, rather than taking those side effects seriously, as they should be. And the third point, I think, that relates to that is how frequently those adverse effects of muscular aches and pains, low mood, fatigue, disturbed bowel function, and so on, can be readily be misinterpreted as being due to aging. And this thing is, well, what can you expect at your age? And I think there is this, I have a sense that, quite frankly, GPs in their role as clinicians don't take nearly serious enough the possibility that their health are being adversely affected by taking these medicines, and that they need to inquire, much more closely and more consistently with as to how they are, and not have any hesitation where they think it might be appropriate in advising a holiday from their statins, for example, to see whether or not those symptoms might improve. I mean, it is incredibly impressive, this sort of almost miraculous recovery that some, if not all, make that I report. And that is, an incredibly important clinical observation. So that is the sort of reply to your points. I don't know. What do you make of that?
I think that's really interesting, and I think it's just going to be a continual balance, I think, of balancing what we're being told we should do and then balancing the kind of holistic care of the patient. I think what you're raising is key, really. Informed consent almost right from the beginning, ideally before it's even prescribed, to explain what the potential benefits are, what the potential risks are, and almost having an open door to say, well, if it's not working, if they are affecting you adversely, not being against just having a drug holiday to see if things do get better, and being open to, patients coming and saying, this doesn't suit me, or this isn't working for me.
Yeah. Well, I mean, yes, indeed. And yeah, I mean, and that, of course, is the ideal way around it. I mean, the problem is that there is a sort of information deficit on our side, on GP side, and actually for any individual, they have no idea, what benefit it might confer, other than the possibility that it's likely to be very small. And as you can see, 60 or 70% of treatment for antihypertensives are prescribed for people with mild hypertension. So that's one point. I mean, I think the other is that we have to be that, I mean, I think, again, I come back to the problem about, the elderly and the rise in those physiological variables with age. Now, this is a natural phenomenon. It can't be considered to be pathological. And yet, one is treating pharmacologically something which is a natural phenomenon, the rise of those parameters with age, with zero evidence that it's going to do them any good. And of course, a high probability that it's going to do them harm, because if you treat something which is natural with drugs, then the likelihood of running into trouble is pretty big. And so I sort of have a sort of feeling that one should have that sort of mindset, sort of a cutoff point of that. Anybody over the age of 80, should they be taking any drugs at all, or how many can one, legitimately cut down on? That's all.
Yeah, I think it seems like, I think hopefully a lot of us at the age of 80 or roughly that thing would say, okay, let's just look which are symptomatic benefit rather than prescribing for any prognostic benefit.
Yeah. I think that's I agree. I think it's a very reliable rule of thumb. Okay.
Cool. Lovely. Does anyone else have anything that they'd like to any points that they'd like to raise, or any queries before we finish?
I'd just like to say that was really an interesting and insightful talk. Thank you so much, Dr. Le Fanu. Those that, when you're doing medication reviews, it's just, it really tears me up when I see the patients that have 28 medications on repeat, and oh my goodness, I mean, that must be so harmful. And I'm a big advocate of what you were suggesting, and do believe that, you know, I think we do probably overprescribe a lot of things, how much benefit is being conferred. And yes, I think that's really opened my eyes to try and be a bit more proactive with deprescribing. And also the other point about deprescribing, I'm currently doing some work for kind of the greener practice side of things within our practice. And actually deprescribing is a really beneficial thing to do in terms of the green initiative as well. So on that perspective, that's another bonus point, I suppose.
Okay.
Fabulous. Yeah. Excellent. Well, thank you so much for your time. That's been really, really interesting, and I think has raised a lot of points. And as I think Dr. Le Fanu mentioned, he does have a book as well, Too Many Pills, as well, that I want to be following up as well, just to find out more as well. So thank you very much for your time, and thank you, everyone.
All the best.
Thank you.
Thank you. Thank you.
Cheers. Bye-bye.